Hi, everyone. It's Mo Bendari, Editor-in-Chief of Ortho Evidence. I have with me Professor of Orthopedic Surgery and Healthcare Evaluation, Dr. Rudolf Poolman, who also works at Leiden University Medical Center. And he has been involved in research for decades. And we're going to chat a little bit today, Rudolf, about just the type of research you're doing, and more importantly, the broader context of the research you're doing. So first of all, welcome.
Oh, thank you, Mo. It's great to be on this orthopod, and it's great to have a chat with you because I really enjoyed those during my fellowship and onwards at MAC. And so it's great to see you, and we can discuss a bit about this.
Okay, so let me just start off by sort of posing a broader question and getting your challenge or your approach to how you're going to be handling some of these bigger healthcare issues. Research is critically important, right? Evidence is critically important in making healthcare decisions. But the challenge we always face is there's so much information. How do you continually use the right information? And if you don't have the right information, how do you identify gaps? How do you decide how you're going to filter everything so you could ultimately have a process that continually improves and allows better care for our patients? So maybe you can speak broadly to the initiatives you're involved in. And that'll help give us some guidance.
Yeah, so this actually started with evaluating our guidelines, that we figured out that about 50% of the recommendations in these guidelines are based on level 4 or 3 evidence. So that's pretty weak recommendations. Actually, these are unanswered questions. And what we started to do is to ask the developers of guidelines to also recommend future research questions. And then we started a process with guideline committees and also the working groups and the Orthopedic Association. Patients, of course, are involved, and insurance companies to prioritize our unanswered questions into a research agenda. And we've done this twice, and now we're trying to see if we can make a modular agenda to see which questions are most relevant to answer. Some questions maybe are answered by other groups around the world, so we can implement them in our guidelines and see how they're doing.
So let me ask you this: you take then the guideline as being sort of the penultimate source of evidence. Would that be fair, or is there something beyond the guideline that you're looking at?
Well, the guideline is one thing, and also we try to look at, so where's the most money involved, and what are the procedures we're doing most frequently?
Okay, so your targets are going to be based on gaps from guidelines and similarly also, which is topical and cost and potential cost-saving maneuvers as well for the healthcare system.
Yeah, and quality improvement for the patients. It's just I need to be clear on this. It's not just cost saving. Sometimes we can find new evidence and it's more expensive, but it's actually much better for the patient. But oftentimes the cost savings are involved if the quality of the care is better.
Well, let me ask you this then. What is your general impression of guidelines that relate to the practice of orthopedic surgery? Do we have enough? Do you believe the quality of the way they're conducted is appropriate? Is the quality of the evidence the challenge? Is it all of the above? Like, what's the issue?
Well, I think the main issue is that we do have a lot of unanswered questions. So the evidence that's out there is also based on randomized trials, if you're lucky. And if it's based on randomized trials, there's often a lot of patients excluded from these trials. Like, for instance, for example, patients with mental impairment in hip fractures, they're often excluded from our trials, also the trials we're running. So if you have a guideline, the guideline does not apply for these patients. And so we need to find trials that actually also include these patients. So real world evidence is one of the modern things to talk about. It's maybe a bit of a hype, but I've got some thoughts how we can cover these issues. Because if you can look at a guideline, especially if there's a weak recommendation, it's interesting how we implement these guidelines today. We say, okay, we developed a guideline. Good luck, here's the guideline, start using it.
Right.
Well, That's what normally happens now. And then there's actually quite an unstructured way to start using this guideline. So maybe we can learn from other groups that you can implement a guideline in a stepped way, like in a stepped wedged randomized design, where you implement the guideline in just one hospital, then randomize in which hospital the guideline will be involved next. So, and then truly implementing these guidelines to see how it affects the care. And since it's a guideline, it applies to all patients. So if you collect the data of all these patients, you can see if the guideline is actually working. So it's an experimental way of implementing guidelines or modulus of a guideline. So maybe it's not a complete guideline, just one modular, and see how it's picked up in this hospital, see what it's the effect on the outcome of the patients. And see if it's actually working for in this real world. So then you have the real world evidence based on true experiments.
That's interesting.
So that's maybe a way to start this.
Well, let me say this. I mean, one of the bigger challenges that I think guideline developers face, one is the quality of the primary evidence. But let's just say that you have a recommendation, you have some sort of recommendation.
Correct.
Compliance with that guideline becomes another issue. So the concept of real world evidence also, I'm sure, builds in some of the barriers and the challenges of implementing guidelines. Is the work you're thinking of doing also going to be evaluating ways in which you can actually implement information? Because so much, you use the example of, hip fracture care, but the truth of the matter is there are probably 50, 60, 70, 100 different guidelines and different approaches, all using bits and pieces of the same fundamental database.
Yeah.
So we don't have unifying guidelines that are applied to everyone. So, there's regional differences. How do you get compliance with even the beginning part of a guideline so you can start testing it? Or is compliance one of the measures in your real world evidence
that
testing?
would be one way of looking at it. So another way is maybe also discuss with the insurance companies to fund, to pay for evidence that's actually working. So for treatments that are working. For instance, there was now a big discussion on Twitter about cementing or uncemented hemiarthroplasties for hip fractures. I think the evidence is building that you need to cement these hemiarthroplasties and not have them uncemented. While in the US, most surgeons use cemented hemiarthroplasties. You need to persuade the surgeons to start doing this. And so if you perhaps pay more for following the guideline than just doing the trick of the surgery, this may help.
That's interesting, and obviously cost becomes a factor as you talked about. So, what exactly, and maybe you haven't gone this far. How do you then, what will be the process in which you're going to be specifically identifying targets for research? So you said that you're going to be looking at gaps from particular guidelines that they identify. Yep. And you'll also be looking specifically at potential, large burdens of cost to the healthcare system. Any other sources of which you'll be identifying, yep, where to spend your time and how to focus it?
Well, the sources where we can identify them is also to have patients involved to see what they really think is important. Because they've maybe other priorities than we have. So patient involvement is very critical to see what they truly think is important to evaluate. And maybe the next level also is if we have the patients involved and we see how the findings are implemented, they can be maybe implemented through the patients. The patients, if they're asked in shared decision making, what do you think? They can also fall back on the evidence they created with us.
Oh, that's absolutely superb. Have you had any experience thus far with including patients in the design of your work? I know you've done quite a bit of work on value-based healthcare, so I'm curious how that all fits in.
Well, in our value-based healthcare group, we also have patients involved that actually underwent some kind of treatment that is a topic of this value-based healthcare project. For instance, for hip arthroplasties for osteoarthritis, we had 2 patients involved. And they actually asked this question, well, why should I sleep on my back following the surgery? And this was a very traditional that you need to lay on your back for 6 weeks, you need to use crutches for 6 weeks. And they challenged this. So why should I be on my back? I'm not comfortable on my back, and I want to lay on my side and see. So we went and looked into the literature and found that there were actually quite some trials that looked at this, and there was no evidence that laying on your side or having less restrictions resulted in more dislocations. So we implemented this in a group of 7 hospitals in the Netherlands to see if it was actually working. And our dislocation rate didn't go up. So this is a typical example of a question of a patient and implement this. And also this is one in the value-based healthcare project. So that's smaller, but in the bigger scheme of things, we have patients involved in our prioritizing sessions. That's made with the Dutch Orthopedic Association, supported by the Knowledge Institute. And we try to identify these unanswered questions together with patients and surgeons and insurance companies to see what are the best questions that we can answer and to put our money for research.
Superb. One big challenge that I think our group in orthopedics recognized some years ago, and we tried really hard to do this, which is collaborative research, right? And more importantly, within collaborative research, diversity within research. So, everyone's so siloed. So as an orthopedic surgeon, are you also looking for different stakeholders to be involved? Oh, sorry, but you mentioned patients.
Absolutely.
Right, but are there other groups? Like, is it just surgeons and patients? Is it multiple medical specialists?
No.
Who's involved in the team?
Well, that's a very good question, and I'm happy you are asking this question, because this is the next level we're working on right now, to get a modular research question agenda and to get other patient folks involved, not only patients, but radiologists, rehab doctors, and also microbiologists to get the bigger scheme of things, infection doctors, not just our silo as orthopedic surgeons, but just wider, on a broader perspective, and to see if we can collaborate and find the real answers. That's what we're doing now.
Got it. And maybe you could speak a little bit, Rudolf, to the general topic areas. I know broadly orthopedics would be the broader context, but are there specific targets within that you're currently looking at in your early stages?
Well, what we're looking at now is the conditions that are frequent. So, for example, osteoarthritis of the hip and knee. We know that a lot of patients with knee osteoarthritis receiving a total knee replacement are not that happy. So how come that about 20% of the patients with a total knee are still having a lot of complaints? So this is a typical group we're looking at. And also one of the big questions that are still unanswered is cementing or not for primary hip replacement. And so we're looking into this with actually a quite new design. I think it's new for orthopedics, but we stole this from the econometrist. And this is a regression discontinuity design. And maybe I can explain a bit about this.
Yes, please, go ahead.
Yeah, so usually the registry studies we're looking at are about the complete population. So lots of patients. And for instance, we've got 400,000 patients in the Dutch registry for implants. And so they're covering 99% of all hip arthroplasties. And the patients, they are from quite young to very old. So, and then we tend to have cemented implants for the older patients, but uncemented implants for the younger patients. So it's quite impossible to because they're quite different patients. So what we're looking at now is we went to look at if there was a certain cutoff for age, because in our hospital here in Amsterdam, we have a age cutoff for instance, for females, it's 65 years old. So if you're older than 65 years old, because of the osteoporosis, we get you a cemented hip. And if you're younger, you get an uncemented hip. So if you compare a 50-year-old lady to an 80-year-old lady, this won't work to see if cementing is better than uncementing. But what we're looked at, since we have these big data right now, we looked at, so if you look at 1 year beyond this cutoff point, so we have a cutoff of 65. So we start looking at the 64-year-olds and 66-year-olds. And these are quite comparable. And since we have so many patients in this database, we can answer this question with about 20,000 patients and get some causal inference that it was not possible with a randomized trial, because it's hard to pull off a randomized trial for so many patients. So this fuzzy regression discontinuity design may help us to find causal inference on this question.
Yeah, and I think that's wonderful, because I think we're seeing so much, and you've used the word real world evidence quite a bit. And I think that's really important, that we always be looking to challenge ourselves with new approaches to looking at information. The biggest fear, I'm sure you have the same always sense of, being a little bit more conservative with data, is we don't know if we're right. If you find something with data, how careful, especially, and I'll just divert a little bit to what's happening in COVID. We're seeing 600, 700 randomized trials on various treatments. We're seeing policies that are promoting, like really promoting drugs, that when you look at the actual paper and you look carefully at the paper, you realize the effect is so small, but it's being promoted as, a cure. That's the risk, right? When, as researchers and academics, we always say, okay, let's be careful about how do we temper that. So in a situation where you're using a new design, or in a situation in which you're thinking about, whether you're going to have a quote recommendation for a path for a trial, let's say, or one of your things, how will you be just using the standards that we typically use? In other words, if it's not randomized, for example, are you going to be less confident, or will you still be pushing the non-randomized data, with confidence, if you believe that effect is real?
Well, that's what we try to learn from other specialties, like the econometrists. Because the econometrists, they were never able to do randomized trials, but they are looking for causal inference in existing data. And this cutoff design, this regression discontinuity design, actually came from the econometrist, because sometimes policies are started, and then there's an age cutoff, for instance, for drinking and driving and stuff like that. And if you compare those, then you can find really interesting stuff. So it's a different way of thinking, and that's what also is needed, that we get out of our silos and start having connections with other research groups to see if we can find these other designs to look at big data and try to find answers.
Oh, superb. Yeah, that's great. When you think now about the future, let's say the next year, given the fact that we still are under some policies of physical distancing, things aren't quite, quote, business as usual, how will you be advancing this initiative?
Well, the good thing is that we can collaborate online, and we can chat on the new research agendas through meetings like we're having right now, so that's possible. So also we have time to write grants and to submit them, and also we've got a lot of data available in these registries we're running in Northern Europe. So there's lots of data available to look at, and maybe with these new designs we don't need to do a randomized trial. Maybe it's cheaper, And also we're thinking of doing different randomized trials, so more pragmatic randomized trials where the registry is actually the endpoint. So you don't need to set up the complete endpoint system, outcome assessor system, because we have an outcome system that's the registry. So for example, we're also running a dual mobility trial now. So to see if this will prevent dislocation in primary hips. We're running, this will involve 1,100 patients. And so the endpoint is in the registry. So it's less complicated to do this. So we should maybe look at less complicated trials that are actually giving us answers without overcomplicating things.
I think you're right. It was many, many decades ago that Salim Youssef and Richard Pito both had written a paper on the large, simple trial. Now, whether it's a randomized trial or whether it's a large
sorry,
trial.
I missed a bit. There was a connection glitch, so okay. I missed that. Sorry.
Yeah. So the point I was just going to say that it was about 50 years ago or so that Salim Youssef and Richard Pito both wrote a paper called the Large, Simple Trial. Yeah. And the argument is whether it's randomized or whether it's observational doesn't make a difference. I mean, it makes a difference, from the purist point of view. But the issue was keep something simple, recruit patients fast, recruit patients in full, collect as much data as you can, and move on to the next big question. Yeah. Trials have become unnecessarily complicated, as you know. And there's lots of barriers then for that purpose. So I think reinventing the large, simple study is a really important movement. Yeah, it's great. Congratulate you on doing that. That's
wonderful. So and maybe also look at the natural experiments. I think there's people like to discuss about this now. For instance, if you break your hip in front of our hospital, you would traditionally get a direct lateral approach, or you would, if you fall a couple of miles away from here, and then you would get a posterolateral approach. So it depends on where you actually fracture your hip, what kind of treatment you get. And so if we look at the hospitals that are in the Netherlands that are having this different approach, usually the hospital has standardized their approach to posterolateral or direct lateral. So, and we can collect these data also in a registry to see if there's a difference. So these are all the patients. So no one is excluded, and it's actually quite a nice natural experiment. Maybe it's not giving the definitive answer, but this is one of the trials we're running right now. We're running this natural experiment, and the hospitals that can randomize, they randomize the patients to the posterior approach or the direct lateral approach for hemiarthroplasties. And we include all patients, also the patients with severe dementia. To find these answers and find answers for all the patients, not just the ones that are fit and are always involved in trials, also the ones that are not fit.
Superb. And, I think on that note, I will thank you very much for sharing with us some of your insights and congratulate you on moving forward. I mean, I think the cycle of research is critically important, but the cycle of improving research and finding treatments that are going to ultimately help us in decision-making are much, much needed. So again, Rudolf, thank you so much for taking time with us today in Orthopod. And we will definitely be looking forward to hearing more about the work you're doing, both in the area of cycle improvement, but also in the area of value-based healthcare.